Hello and a very warm good evening to you all. I, Solu Gautam, welcome you all to this 110th session of Mero Eye Talks webinar. Today we have a very special guest, Dr. Nitesh Barot, and he will be talking on topic Ortho-K and vision therapy synergy. Before he begins, I would like to give a general introduction. Dr. Nitesh is an MC Optom, Fellow of British Dispensing Opticians and International Academy of Orthokeratology. Furthermore, he is also a myopia control specialist. I welcome you, Dr. Nitesh, on the behalf of Mero Eye Foundation and all our participants. Over to you, Doctor.
Can you see my slides yet or no, Solu?
No, Doctor, I can see it yet.
Okay, 1 second. Has it come on or no? I am having issues here. Sorry. Okay, can you see me now? Yes, yeah. Yep, now I just need to share the screen.
But the slides aren't still visible.
Yep. Is my slides visible to you?
No, Doctor, not yet.
How about now? Okay, hold on. Yep, we are on now. Yeah, thank you so much for the great introduction. And also thank you to Mero Eye Foundation for inviting me to do a talk today. And thank you, delegates. I believe it's about 8 p.m. at the moment night in Nepal and India. And obviously it's 3:15 or 3:20 in UK. So the talk I'm going to give you, sorry, it's not, 1 second. Before I do the talk, I'd like to mention that everything I'm presenting today I have no interest in any products or anything I'm presenting today. So it's just a disclaimer. And the talk I'm going to talk about is Ortho-K and vision therapy and the synergy between the two. Now, if you add 1 + 1, it should be 2. But I look at it this way: when you have Ortho-K and vision therapy, it's actually 1 + 1 = 3. So let's see why. Now, this is my practice. I have got a huge practice, which is 2 floors. And in my windows, marketing is what I've got here is corneal therapy, contact lens specialist, orthokeratology, dyslexia, colorimetry, and sports vision and school vision. Now, if you look at sports vision, school vision, and dyslexia, there are 3 parts of the vision therapy. So in a way, I'm doing quite a few things with my vision therapy. Now, the learning objectives here is to understand what vision therapy and orthokeratology are, and also to understand the similarities between the orthokeratology and vision therapy. Understand how orthokeratology and vision therapy can benefit an optometric practice. Understand the importance of practice culture to know where to find additional information on vision therapy and orthokeratology. Now, to do either one of them, to be honest, you need to be a specialist. How far will the patients come to see you? If you're a specialist, obviously they'll look for you, they'll find you, and they'll come to you from wherever. I get patients from Middle East, I get patients from Europe. I even had patients, a whole family from America. And yet in America, they're doing all these things. So somehow they found me, and somebody must have recommended me for them to turn up at my practice. What you got to look at also is how replaceable are you in your community. Now, in optometric practices, if you're doing the usual routine stuff, there are too many people doing that. Refraction is everybody's doing it. So you can be replaced at any time. And nowadays, even the modern, auto refractors, everything is coming in. We are replaceable. AI is coming. So we have to be different. We have to be a specialist. And how dependent are you on your commodities? That means, are you just there to sell products only? Or are you there to provide a service, a specialty? If you're dependent on commodities, then there is competition to deal with. With specialty, you are a specialist, and therefore you will find a niche market and obviously have a good earning and living. How challenged do you want to be? Now, the challenge means you need to specialize. In order to specialize, you need to go out there and learn what's available. And here, like Mero Eye Foundation, and there are others where I see now people are going on, Zoom and learning about these specialities. And the more you learn, the better you get. How long will patients wait to see you? I've had patients who will wait for 6 months or even a year to see me, because they know that I do certain things in my practice which somebody else doesn't do. So therefore they come to me. The reason I put this picture here is it's a film, basically, I think it was in 1990s, being a specialist. And that's why I wanted to talk about being a specialist. This picture, actually, I got the idea from Nathan Bonilla. He's a US optometrist who actually practices both also, Ortho-K and vision therapy. And he also did a lecture like this in the past. So that's where I got this idea of this slide. So I need to thank him for that one. Benefits of specializing: you're going to get more respect, because if you're a specialist, people will respect you. And that's not just only the patients who are coming into you, the public, but it's also going to be your own professionals who will also look at you, that you do specialize in something, and they will actually refer patients to you. There will be more talk about you, even by patients and practitioners and educators and doctors, etc. And that's a word of mouth. You will have more control over your practice because you're doing a specialty. Therefore, you're not just dependent on those commodities. So therefore, now you are the main important person. You'll be less dependent on third parties. There'll be more freedom from, in the USA, they do insurance work, so you'll be more, free from that sector. In UK, I tend to do a lot of NHS work, but this gives me something else to do. So it's that. In your case, if you're doing just retail or you're part of a corporate sector, again, this gives you a little bit of an extra, benefit. Now let's look at orthokeratology. This is just not a lecture on giving you the full orthokeratology. Here, I'm just trying to give you just a taster. So looking at orthokeratology, it's a method of molding the cornea with contact lenses to improve unaided vision. Now we can call it corneal molding, corneal refractive therapy, general vision shaping, and there are other various names you can put in there. So that's what orthokeratology is all about. What's vision therapy? Optometric vision therapy is a progressive program of vision procedure to help patients develop or improve fundamental visual skills and abilities to improve visual comfort with ease and efficiency. Change how a patient processes and interprets visual information. Now here you are going to be looking at binocular vision problems. You will be looking at somebody who's getting headaches, who's got, you are dealing with the multitude of problems which you're going to try and solve, like school kids who have reading problems, etc. So it's a vision training. It could be sports vision, which I mentioned earlier with my, window where I put what I do. Now let's look at the theories, different theories of myopia development. There is genetic factor, nutritional factors, myopia related to personality, and psychological factors. Now, a lot of people don't look at that. Nutritional factors, genetic factors are aware of it. But with the myopes, they tend to be quite personality-wise, they tend to change. If you think of it, they want better vision every time they come to see you. If you're doing a refraction on them, you'll find the myop wants it sharper and sharper. Myop tends to get agitated very quickly. So they have that, breakdown coming up at some point because of near point stress. So myopia related to vision disorders related to stress of near work. Now Skeffington in 1964 and Burnham in 1980 did specific research on this. And that's very, very important when you're looking at Ortho-K and vision therapy. Myopia control has two aspects to it. One is functional, other is optical defocus or visual training, or be structural, and therefore Ortho-K is required. Now, when I say structural, it is the axial length that's changing. So we need to control that axial length. And Ortho-K has been known with research now for a number of years is the best method to use to control axial length. So management of myopia for structural purposes, Ortho-K is a very, very good tool. There are other tools like atropine, etc. And also MySight soft lens is now available. But the main focus at the moment is Ortho-K. And that's a specialty again. So you need to be aware Ortho-K is a specialty. With vision therapy, there are advantages with Ortho-K and together, which I'll mention in a minute. Now, Skeffington, I mentioned earlier, states that myopia is an adaptive change to resolve the mismanagement between vergence and accommodation. Now, the problem today, we are all looking at digital devices and looking at the near, what is happening with the kids looking at near range. But in reality, if you look at all the research that's found out, the more educated you are, the more myopic you become. So looking just at the digital devices, they may not be the reason for the myopia boom. The real reason could be education. So we need to teach kids how to deal with that. Now let's look at Burnham. He attributes the drive for convergence to localized closure, both to sympathetic activation associated with attention and mental effort during near work and to psychological stress. So in order for us to look at close range, we are putting a lot of effort. And that is why education-wise, that's where the problem comes in. Because too much emphasis on education and people are now doing tuitions and all this, spending a lot of time. Even now, home studies have arrived. So there's more studies going on. They're using digital device to read on. So again, that's going to be a big problem. Psychologically, there is stress. The sympathetic and parasympathetic systems are in war, basically. Consequences and adaptation expected from sustained near point stress. Now, when you get these patients, you're now getting them regularly. They got astronomic complaints, a reduction in visual efficiency, and concentration problems. Now I'm getting in my practice people coming in, even older people, 20, 25-year-olds coming in saying, I cannot concentrate. I'm getting memory loss. So think, what's going on here? It is the near point sustained stress that's happening. Watery eyes, headaches, eye strain, all this is coming in now. We are seeing a lot more. The more we are now staying indoors, the more we are going to get these problems occurring more and more. So we have now a fight or flight situation when you got near point stress occurring in a person. It is the fight for survival and success in the near point stress environment that leads to the development of myopia. It's simple. Because near point is under stress, the eyeball is now going to grow. The reason for that is because peripheral defocus has been ignored. We are now considering close range. The flight response occurs where the individual avoids near work. So now the kid does not want to read. He does not want to work, do anything, especially school tasks. And this situation often leads to the development of reading and writing problems. So let's look at visual hygiene. Visual hygiene is part of Ortho-K or vision therapy. So we should be advising on posture, illumination, using vision efficiently with minimum energy expenditure. So here again, we got to look at how they can do certain exercises in order to reduce that near point stress. Illumination, again, give them enough illumination to see. Posture is very, very important, because if they're sitting up straight at the right distance with a laptop or reading book, it will make a difference. So, when a dentist tells a child, go and brush your teeth every night properly and in the morning, you need to tell them the same thing. Yes, go and make sure your posture is right, get illumination right. All this has to be advised. Now, what's the synergy between Ortho-K and require further training after graduation? It's very, very important. The doctors who are truly interested in their patients' long-term success will succeed. Practice culture of excellence. This starts from your own practice. Both Ortho-K and VT require significant post-graduation level training. You can't either what I just repeated. And again, if you're not interested or you're just dabbling, you will not succeed. So it has to be from top down. So it starts with you in your practice. Then your staff below you all have to be part of it. And staff have to believe in this. Staff are also proud to work at a practice that cares enough and is specialized in the services. It's important if the staff knows that you are a specialist in something, they'll talk about that. They'll be happy. What is the best way to get a staff member to believe in Ortho-K? Fit them. As soon as you fit one of your staff members, they really, really start talking about it. And they're talking to the families, they're talking to the friends, they're talking to everybody who walks into the practice. They will talk about it. That's for sure. In my practice, when people come in, the first thing they see is nobody is wearing glasses. We got spectacle dispensing there. And the thing I always say, even in my test room and examining, is that, look, my staff don't wear it. Have you heard about this? Ortho-K. Have you heard about vision therapy? That's the starting point. What is the best way to get a staff member to believe in VT or visual training or therapy? Fix them or treat their children. And I'm sure if you look and ask your staff, you will find that they've got children who may be affected in some way or the other. They may have reading problems. They may be myopic, whatever. Try and help them. And this, again, I said earlier, but why is this most important to fix them or fit them? It's because they are the ones who will talk and market your practice. Ortho-K and visual therapy have similar demographics also. The patients who come for this tend to be very detail oriented. You see, your myop patient will look at your glasses inside out. You get a hyporic patient, they just put them on happy and they go away. But myopic will always complain of something, but they'll do their research. They'll want that coating. They will want all this. So yes, they are the detail oriented people. So if you talk to them, explain it to them, they will actually go for it. Patients who are concerned about vision, again, they are very, very concerned about their vision, and the slight change, they do appreciate it when you change them. Patients who are interested in investing in long-term solution, when you get Ortho-K or a visual therapy patient, they tend to be interested in investing in the long term. They want the better for their kids or themselves. And they tend to be typically younger patients, though I should mention that in my practice, I do get 55-year-olds and up also. But significant adult subpopulations do exist. There is an overlapping market. Patients, doctors, and staff build strong relationships. Patients get to see other patients. So when they're coming into your practice, either they're saying somebody is inserting and removing your Ortho-K lenses, or they're doing vision therapy and they see some child running around with doing some exercises. Yes, this is what, again, self-marketing. It's happening while in your practice. Although with COVID situation, we have to keep them distance apart. Remember, in UK, we have now 1 meter to 2 meter distance apart and all the other stuff that comes with it. But still, we are now doing it. We just came out of lockdown. So this is what we used, before we didn't have any of that, but we still now started back on this. Patients will do your marketing for you. They will, once they are taken care of, talk about this. They go out there and market. So specialty itself, doing both, helps you. When communicating about either, your deep knowledge of different specialty area will be apparent. So if you are knowledgeable and have done all your research, you've gone and to all the conferences that were available in the past or in future, and also these webinars now, then yes, you will have the knowledge. So therefore, when you talk about it to your patient, they will know that this doctor is talking about what he knows. And also your promotional material should be targeting for both populations, for VT and orthokeratology. But very most important, which you need to look at as an optometrist, it is your specialty. It is a conversation about their visual problems and concerns and the solutions we offer. But what is the real commonality? Optometrists are the primary providers of both Ortho-K and vision therapy. We are not dependent on other professionals to achieve respect, success, and profitability. These are ours. You know, we are trying, some of the optometrists are now trying to be quasi-doctors, as I call it, and going into medical. We do not need to dwell on the ophthalmology professions. They can help us. This is our specialty. So why do we need to go on to the other side? We have got something special here. You know, specialize and use that. That is ours. It is a vision-related problem. We can solve it with Ortho-K and vision therapy. Now, this slide I've actually stolen from a recent article from a review of optometry, which you'll see at the end is mentioned in the references. Soo Jin Nam Opton from Sydney, Australia, actually wrote a recent article. And I pinched this because binocular vision and myopia management, these are the options you have got when you get a patient, which I'm going to go in a minute for you. There are 4 options: binocular vision, myopia management. So you do binocular vision first correction, and then you do myopia management. Or you can do binocular vision first, then myopia management, or do it together. Or just do myopia management if there's only myopia management required. Now, this is where I'm going to show you a case record of one of my patients. Patient is VR. His date of birth is 8/3/1995. He came to me on 22nd of May 2005. Minus 550 right eye, minus 050 times 175, VS 69. Left eye, minus 850 minus 0.75, 156, VS 636. An exo deviation in the left eye. He was discharged from hospital high services at 7 years of age, told nothing can be done with left eye and it's a lazy eye. Family history, myopia in the family. Father registered blind, has retinal detachment in one eye and maculopathy in the other. All in his family have minus 18 and over, except his sister and 2 of his cousins who are all with us for myopia management. I'm going to talk about another patient, then I'll come back to the other one in a minute. Now, look at this. This is a very contrasting patients. If you look at the first one, he was born in 1995, and I saw him in 2005 when he was 10. Next patient, born in 1991, I'm seeing him in 2018. So you can see how old he is there. Now his RX was plano minus 175 at 180, VS 65, N5. Left eye plus 525 minus 150 times 8, VS 660 and N8. Now remember, this is a plus prescription. Cyclo was +2, -175, 180. Left eye was +250, -150 at 8. He was discharged from HES, hospitalized service, at 8 years of age, and was told he has a lazy eye. All our exams since then, he was prescribed balanced lens in his left eye and was told nothing could be done as it's lazy. Current specs wearing plano -125, and left eye was given -1. I mean, can you believe it? A +525 is given a -1 and a balanced lens. He started a new job as a games developer and was getting, and I'm talking about computer games developer here, this guy, and was getting headaches, eye strain, and issues with 3D. Now, these headaches and eye strain have been virtually with him all his life, but they increased quite dramatically. So he did his research and found me. He actually travels from Scotland to see me in Leicester, which is quite a far distance. Now, the current status of BJ, you got to remember, we worked on him. We did the right thing. So we did vision therapy, provided him initially with varifocal spectacles, and then we even did Ortho-K later on for hyperopia. But what the outcome was, within 12 months, his right eye went to 6.5 and N5. VA was left eye 6.9, and his actual near vision improved also, which we were surprised, to N5. That, if you remember, we did a fly test on him and for further various stereopsis tests. He now had full stereopsis. He doesn't have any more eye strain. He's actually enjoying 3D vision, and he's actually designing games at the moment, and he's so happy. And he's actually paying us a lot of money too, but that's besides the point. The actual what happened to him is a fact. And I've not given you all the topography maps and that this time because wasn't time permitting, but I could have gone through the whole thing. But this is what happens with vision therapy and Ortho-K working together. But let's go back to the first patient, Vijay. Remember that kid? He improved. We put him on vision therapy as we had not improved. When we put him on Ortho-K, his VA did not improve. So what we thought, let's put him on vision therapy at the same time. And guess what? He's 675, 025, VA 66. But the left eye, which is where the dramatic change came in, -975, -0.75 at 156, VA 675. He has now left us to see if we can have LASIK or lens implant. But let me go back to his slide again to beginning. Look at what the myopia. This is guy who's now 25. 550 to 050. And 850, 075. So if you look back, actual change in RX is quite controlled, managed. Okay, it's increased, but not dramatically. So before he left us, we did a topography to make him, he was stable. His RX was stable. Before I referred him to be seen at Midland Eye Clinic to be seen by Dr. Shah for either LASIK or lens implant. And I've not received any message yet, but hopefully he should be okay. But can you remember his family had -18 and over. So myopia control was achieved quite significantly. But at the same time, his VA was improved. I mean, if you remember, again, the VA was 636 in the left eye with spectacle correction and 6.9 in the right. And look at it now, 6.6 and 6.75. So if you look at this, it's a fantastic, thing to do for a patient. You're not only controlling or managing myopia, but you are improving vision. And Ortho-K is not just for myopia. It is for hyperopia too. We can treat presbyopia. I've talked about this in various lectures before, and maybe in future we'll do this again. But it can be done. So this is where I want to now say to you, let's look at where you can find information on Ortho-K. American Academy of Orthocardiology, myopiccontrol.com, euro.eu, our on-site BIPOC, which is for Asia. At the moment is under reconstruction, but we'll have the same information, and obviously you can join and get more training on Ortho-K. Also coming out or soon to be launched is International Academy of Orthocardiology, myopiccontrol.com. So you have to be a member of one of the sections to have access to that too. So you will become a member of IMOC. I would always advise everybody to study, go to conferences, and at the same time get a mentor, and then also think about fellowship for the orthocardiology IMC. College of now vision therapy. Again, there is vast information available on the internet. But if you go to College of Optometrists in Vision Development, so much information there you can get hold of. Optometric Extension Program Foundation. Again, their website oepf.org. The article I just told you about binocular vision management, which I took review of optometry article by Sujin Nam. Again, that was good. Review of optometry. If any of you want that, you can actually email me and I'll send you the link for that too. Again, I'd like to thank you all for listening to me. And Solu, I'm going to pass this back on to you so we can have any questions if there are. Thank you again, Mero Eye, for inviting me.
Okay, thank you so much, Dr. Nitesh, for such a wonderful session. Now it's time for the discussion session to begin. I'll be reading out the questions for you, Doctor. Are you ready to take the questions?
Yes, I'm ready. Thank you.
Okay, let me check out the questions that our attendees might have raised. If you are having any queries, then you can come up with your questions on our chat box. Dr. Nitesh will be happy to clear all your queries.
I think everybody's tired by the looks of it. It's late night.
Actually, Doctor, we could not get any questions till now. We will be waiting for a few minutes if anyone is willing to ask.
Yeah, no problem. Don't worry.
Yeah, Doctor. Yeah, we have our first question by Miss Babita. Thank you so much for your question. Can
Hello?
Can hyperopia be controlled with Ortho-K?
Yes, see, Ortho-K, you got to look at it. There's two functions of Ortho-K. One is to actually reshape the cornea in order to get rid of the refraction you have got. So hyperopia, yes, it's another refraction problem. So it can be done, yes. The method is different to where you're flattening the cornea. Here you're actually stiffening the cornea. Hope that answers the question.
Yeah, Doctor, thank you so much for your answers. Moving forward, we have another question by Mr. Deva Mathi. Thank you so much for your questions. His question goes as, what type of vision therapy has been given for the patient, sir?
Which patient are you talking about, the myopic or the hyperopic patient?
Yeah, his question is not clear, but he's just asking for what type of vision therapy.
See, both of them had actually amblyopia. So your main first start point is, we see what happens in UK, as far as I know, and I presume it happens around the world, where we do patch treatment until when they're up to 8 years of age, and we stop and say nothing more can be done. But I have found when I've actually done this on adults, it does actually improve. So the first part of the vision therapy is to actually do a patch treatment. And where you, in the practice, you actually get them to read a letter at a certain distance and then increase the VA by moving them away from that chart. So therefore, with the patch treatment, you make that other eye, which is the one which is the amblyopic eye, work harder. There are now computer software available to do that too. So they can do some home exercises. So in order for that, your main target is to get the amblyopia, vision to come back to that amblyopic eye. And it does happen. And the fantastic thing happened to me where I got involved in vision therapy was one of my first patients earlier on in my career of orthokeratology was there was a diabetic patient. He wasn't part of the orthokeratology itself, but he was a diabetic, and through his losing control of his diabetic, he actually became insulin dependent, and actually he had one eye, first of all, neovascularization, and he had lost the vision completely in macula in that right eye. Now the left eye always used to be amblyopic eye. Now his vision in that eye was 660. But after losing that right eye, the left eye, suddenly after within a year or 2 years, it actually became 6.6 again. So there was no other issue except that that eye was not being used. It was being ignored while the other good eye was there. And that's what made me think that we can exercise with these people and make their eyes work back. So that's what vision therapy is about: patch treatment, redoing it again, and then making certain exercises. With myopia, you have to do also peripheral vision training. So you can actually reduce the numbers also with vision therapy. Hope that answered the question, Solo.
Okay, thank you so much, doctor. Moving forward, Mr. Fakhruddin has also asked, was vision therapy given in office or at home? What was the vision therapy given for the patient, sir? Would you like to add something?
The vision therapy you're talking about to take it home, we give them actually a chart with letters in it, or E's, or any pictures in it, where what they do is they stick it on a wall at approximately 3 meters, because the average house size is, you need to be worried. So they measure to that distance, stick that chart with the good eye closed. They go and read, as I say. So that's homework too. So what we do in the practice is what we tell them to do at home also. So it's the same thing. But the problem is when you're initially asking them to do it at home, they're not motivated because they don't see that change coming quickly. So you have to reinforce that in the practice. So my staff who are working on that all the time, saying, look, now when you came in, you were virtually next to the wall when you were looking at that. Now can you see after, an hour or so, can you see a little bit better, a bit further away? That's what makes a difference. And yes, you will see if you practice this, even just with minute amount of vision therapy is basically just looking at something, forcing that eye to look at it. It does improve. Thank you, Fakhruddin, again for the question.
Okay, thank you so much, sir, for your clarification. Moving forward, Asmita ma'am has asked, I want to know about your taking the patient selection. What sort of patient, even if myopic, does not fit to walk hand in hand with vision therapy? I mean, do all the patient fits in?
I didn't get that question. Solo, can you just repeat what you asked? Sorry, I didn't get that. Can you
Okay.
repeat that for me?
I want to know about your patient selection in the vision therapy. What
Right.
sort of patient, even if myopic, does not fit to walk hand in hand with vision therapy? I mean, do all the patient fits in?
You see, what you got to look at is what is the reason for doing vision therapy. We say if it's a structural axial length you're doing, basically correcting, making sure that the axial eye, the length does not increase, then orthokeratology is the first choice of treatment plan for me. After that, we are looking if there is anisometropia, where the two prescriptions are different in two eyes. So we want to try and get them together. Now, if there is a VA difference between the two eyes, at least over 2 lines, then you need to also do vision therapy. Now, if that's not the case, if let's say both, for example, are -4, let's say one is -4 and -5, and they're both coming to 6.5 after your Ortho-K, I do not do vision therapy initially. So I leave them alone. But what happens is after, let's say, a year or 2 years, the patient is coming in and you're doing a reassessment, and they start to say, look, I'm getting some form of headache or something, then I will think, let's look at where the vision therapy will help them. And I suggest that. And we have found that when we have suggested that vision therapy is not only help them with their strain, but it's also helped them with reduction in RX, where I've actually had to reduce my RX on the Ortho-K, where I've had to do the refitting of the Ortho-K with an improvement in vision. So, vision therapy does actually help, and especially if there's pseudomyopia, then it's going to help definitely 100%. Because some people become pseudomyopic after a while. especially with the education, with now, as I said, we are staying in, that's going to be happening a lot more. Pseudo myopia is going to be coming in a lot more, and we're going to be overcorrecting with spectacles or contact lenses. We're not going to look at the root cause of it. And if it could be just near point stress, especially adults, then we can solve this problem just by vision therapy. I hope that answers the question again. So,
Okay, thank you so much, Dr. Nitesh, for your wonderful answers. Moving forward, we have another question by Miss Aisa. Thank you so much for your questions, Aisa ma'am. What about astigmatism and orthokeratology?
again, astigmatism is correctable, fully correctable nowadays. I mean, there are now you can do, I've talked about this, I think, on the other talks, where I've actually mentioned that astigmatism is no longer a barrier. We can treat with orthokeratology. So if you do custom design lenses, it's very, very doable. But again, remember my lecture was speciality. Become a specialist and you will get there to do all this. I mean, if you look at my patient example, was a -9 or -850. Now, a few years ago, it wasn't impossible to do it. Even today, people are saying it's not possible. That's why I said off-label, you can do that. Does that answer the question? So it can be done with Ortho-K.
Okay, thank you so much for your answers. Moving forward, we have again another question by Mr. Fakhruddin.
Yes.
In cases of amblyopia vision therapy with orthokeratology, would you correct the good eye by Ortho-K to let the amblyopic eye fully correct? Is that an option, or you would prefer to fully correct both eyes and pass the eye outside?
No, my case, I will fully correct because my big problem is what I'm worried about. If it's a minus myopia patient, then we do not want myopia to progress. So it's a full correction for both eyes. If it's actually the other way around, where it's hyperopia, then I may undercorrect the other eye for it to get longer. So it will actually correct itself. So hyperopia is a different ball game where you can actually undercorrect the good eye, because you got to remember, if you are getting the other eye to work, hyperopia, the eyeball can get longer by certain exercises. So therefore, my hyperopia will come down. So the vision therapy will work for that. Especially if it's accommodation related, or it's related to convergence insufficiency, then that will work. So yes, undercorrection, yes, Fakhruddin is right again on that. Yes, we would undercorrect plus number, but minus, no. Minus, my biggest priority is my myopia management first, and for that I will correct them fully both, because I do not want the eyeball to get longer. Hope that answers the question.
Yeah, doctor. Thank you so much for your answers and clarification. I guess we have only this much of questions till now, and we will be waiting just for a few minutes if anyone wants to come up with their questions. Is that okay?
Yeah, no problem. Don't worry.
Okay, doctor. We have another question by Ajay. Thank you so much, Mr. Ajay, for your questions. How you retain your patients? Is it due to insurance in India?
No, no,
In
no. I'm
India,
in UK, so my patients actually pay privately. The ones who are on vision therapy or orthokeratology pay privately. We have got a national health service system here, but that they don't come under that category. So therefore, it is all privately based. They pay for it. There is a payment plan system I use. Maybe in future I can do a talk on that. But there is a system which I use in my practice, which is a way to deal with this, because if you charge them in one go, it's quite a large expense, especially if they need both at the same time. And you have to charge what you're worth. Your specialty is what you train for. So therefore, you can't just, give it away. Hope
okay,
that
thank you
answers
so
the
much.
question.
Yeah, doctor, it
I'm
definitely
not based
does.
in India, by the way, whoever asked the question. I'm based in UK, in Leicester.
Okay. We have another question by Mr. Ananta Paudel. Thank you so much, Mr. Ananta, for your questions. He have mentioned that it may be out of topic, sir, but
Yeah.
can you please say if it is possible to correct ptosis with certain type of contact lens? Would you want to add something to this question?
Here is not, I mean, I don't see many, but yes, it is possible to use scleral lenses where you can put a flap on the lens and which will hold the actual lid up. So it can be done, yes. So that is possible with contact lenses if the edge is designed in such a way to create a flap for the lid to be held. So if you use a large enough, sufficient enough lens with the right flange on it, it can hold it. I hope that
Okay.
answers that question too. And I bet
Yeah,
skull lens fitters were watching this, so maybe they could chip in here.
I guess we have answered almost all the questions till now, and that was indeed a great session by Dr. Nitesh. Considering the time limits, here I announce the closure of discussion session, and I would like to thank you all for coming up with your queries and making the discussion session more interactive. I would again like to express my immense gratitude towards our presenter, Dr. Nitesh, for sharing his invaluable insights, and to all the attendees for their endurance. Also, I would like to thank all the direct and indirect helping hands for the iTalks program. Before wrap up, I request our today's presenter, Dr. Nitesh, to share his few words to our program.
Thank you again for everybody listening in, and I'd like to thank you, Solu, for being a very good co-host, and also to Kapil for inviting me to talk on Mero Eye. And it's been a great pleasure, obviously, to be working with you guys. So again, well organized. Thank you again for inviting me, and thank you to all, and be safe, please, in this COVID situation. Please, please, please take care of yourself and your family. Thank you again for inviting.
Thank you so much, Dr. Nitesh, and it's our immense pleasure to have you with us today. We would love to see you again in the future.
Look forward to thank you again, Solu. Bye.
Herewith, I announce the closure of today's webinar, hoping to see you all again tomorrow. Stay safe, stay connected. Thank you.